Thank you, Dr. Morrison. Our next speaker is Ms. Gabriela Burrows Deluca. She is a program officer with the Open Society Public Health Program, where she works with grantees to promote the right to health through legal research, advocacy, and strategic litigation.
Thank you. Can you hear me? Yes. Thank you so much. I'm really happy to be here and to have this opportunity to talk to you. For those of you who are not familiar with Open Society Foundations, we are one of the world's largest philanthropies in human rights, and we're also one of the largest donors in the palliative care field. So I'm going to talk to you about palliative care and access to controlled medicines, which is a huge topic, and I could talk about it for hours, but I will focus on a few key themes on human rights, on access to medicines, and then I will zoom into the Latin American region. So just to set the scene, the way we define palliative care at Open Society Foundations is that palliative care is the holistic management of physical, psychological, legal, and spiritual problems faced by patients with life-threatening illness and by their families. Palliative care can be delivered in a variety of settings, including hospitals, outpatient clinics, residential hospices, nursing homes, community health centers, and at home. It is fundamental to health and human dignity, and it is a basic human right. It can and should be provided alongside curative treatment that begins at the time of the diagnosis. And note that this definition includes legal support, which comprehends, for example, legal support in preparing wills, dealing with inheritance, and planning for childcare after the death of parents and grandparents. Now, there's an enormous unmet need for palliative care worldwide, and I apologize if I repeat some of the information shared by my fellow panel members, particularly Ms. Daniela Bass and Dr. Nata Menabde. This is to make sure that you retain some key points. But I will just briefly touch on some of those things and dive deeper into country examples, particularly looking at Latin America and looking at some of the concrete work that civil society has been doing using legal tools to advance the right to palliative care. So, estimates indicate that there are approximately 5.5 million cancer patients and 1 million end-stage AIDS patients needing palliative care annually. Next slide, please. Within that population, the biggest proportion in need of palliative care corresponds to older adults, of which 69% are over the age of 60. With demographic and epidemiological changes, the number of people above the age of 60 is expected to double by 2050. Many suffer from severe pain without having access to pain medicine like morphine, which is subject to excessive regulatory barriers since it's on the list of international and national controlled substances. When it comes to the UN, palliative care and access to medicines for pain relief are recognized under international human rights law and are included in the interpretation of a number of UN conventions. So there is really no good rationale for why there's such a large gap in access to palliative care worldwide, considering that the gold standard for treatment is morphine, which is generic and available at low cost in most parts of the world. The UN Special Rapporteurs on Torture and on Health have issued a number of joint statements on this topic, and they have stated that the denial of access to pain relief, if it causes severe pain and suffering, may amount to cruel, inhuman, or degrading treatment or punishment. And in 2015, the Inter-American Human Rights System adopted the very first human rights treaty to explicitly talk about a right to palliative care, the Inter-American Convention on the Rights of Older Persons. This convention requires countries to provide access to palliative care without discrimination, including to palliative care medicines. But what does that mean for countries, and what have they been doing wrong? 20 palliative care medicines are currently on the WHO list of essential medicines. Still, it is widely unavailable. So in the Latin American region, which is covered by this convention, the average morphine consumption per capita, which is one of the ways of looking at the scene of access to palliative care, not the only way, but the average morphine consumption is about 25 times lower than the average consumption in Scandinavian countries, for example. where access to palliative care is reasonably high. This discrepancy means that millions of people are suffering because they cannot access pain relief. More than 1 million new cancer patients are diagnosed in the region each year. And in a recent report on the negative impact of drug control, the Global Commission on Drug Policy has called this a global crisis of avoidable pain. The Colombian human rights organization De Justicia, which is supported by Open Society Foundations, recently analyzed the laws and the policy framework in the country and in 7 other Latin American countries. De Justicia's research revealed many examples of disproportionate barriers that block access to palliative care. These include restricting or limiting those who can prescribe or handle opioids, as well as limitations on the amount or length of prescriptions. So although Colombia has passed model legislation on palliative care in 2014, they have their national palliative care law, the barriers of access remain high because decades of drug policy and the war on drugs in Latin America have prioritized strict control of opioids and have failed to provide for their use as an essential medicine for people in need of pain relief. So this is the flip side of the opioid epidemic. This is what's happening in other parts of the world. For example, there are Colombian regulations that require onerous security measures in place just to transport medicines. So for doctors who provide residential care, they need to transport medicines in a locked special safe with witnesses accompanying them. And there was a story that was covered by a Human Rights Watch report on Colombia that really shows the level of despair and lack of access in the country. In September of 2008, the mother of a cervical cancer patient in Cali, she placed a classified ad in the newspaper El País, and in it, her daughter wrote, "Pain is killing me because for several days I have been unable to find injectable morphine in any place. Please, Mr. Secretary of Health, do not make us suffer anymore." The woman in Cali is not alone. Onerous restrictions on opioid medicines mean that many pharmacies in Colombia do not stock morphine, and patients routinely struggle to obtain these medications. In Argentina, for example, doctors must send a copy of all prescriptions to government authorities within 8 days of issuing them, and they cannot prescribe it for more than 10 consecutive days. The regulations for pharmacies that stock opioids are so onerous that many choose not to stock it at all, and because doctors and clinics who specialize in palliative care are often concentrated in major cities, even in countries such as Uruguay, which has very progressive drug policy and guarantees the right to palliative care, patients living in rural or impoverished areas are often unable to access these medicines. And in Panama, one of the lowest morphine consumption rates in Latin America, doctors rarely prescribe opioids, due both to the stigma of opioids and a lack of training. This results in low consumption rates, which in turn results in low estimates of opioid need in the country, and then results in a low import of these medicines, feeding into a cycle of low demand and little availability. Next slide, please. Sorry, I've been moving faster. So, in order to make human rights and public health commitments meaningful, governments need to do more than just adopt national laws on palliative care and to speak about respecting the right to palliative care. They need to identify the factors that are actually on a daily basis impeding access to controlled medicines in their countries. This includes not only regulatory barriers from federal to local levels, but also the ways these policies are implemented in everyday medical practice. Palliative care advocates, for example, can work with human rights advocates to understand, document, and negotiate changes in regulations that restrict availability and access to essential medicines. Back to Colombia, the organization I mentioned, De Justicia, is now working to develop a diagnosis of access barriers to palliative care in the country. And by reaching out to doctors, pharmacists, patients, advocates, and government officials, researchers, human rights researchers, are figuring out whether these barriers are real, whether they're created by habit, where they're exactly found, who are the gatekeepers, and creating spaces for negotiations between decision makers and advocates. So you can go on to the next slide, please. I've mentioned a number of things quite superficially, but if you want to learn more about Open Society Foundation's work on palliative care and get into any of these issues in more depth, we have a number of resources online. So if you would like to learn more about the work of De Justicia, which is spelled D-E-J-U-S-T-I-C-I-A, De Justicia, for those who speak Spanish, their website is very comprehensive. And for some of the resources in English that Open Society Foundations has helped produce, you can access our website and where you can find this toolkit on how to use the UN human rights system to advocate for access to palliative care. In this toolkit, we refer to a number of UN conventions and mechanisms that advocates can use to fight for the right to palliative care. And also 3 fact sheets that refer more broadly to palliative care and human rights and look specifically at older persons and children's rights. So thank you again for the opportunity to speak to you all. I thank you for your attention. And I'm happy to talk to anyone individually afterwards, or you can also find me easily through our website. Thank you.
Our next speaker is Mr. Paul Conway. He's the president of the American Association of Kidney Patients. He will speak on the importance of patient advocacy in health service decisions and share his personal experience as a kidney transplant patient. He is actively involved in multiple patient-centered national healthcare transformation initiatives aimed at increasing the inclusion of patient preference information and patient-reported outcome data across federal government and evaluation processes. Mr. Conway, the floor is yours. Thank you.
At the top here, before I move through my slides, and I'll do that fairly quickly to get to a couple that I think are quite germane, I'd like to say 2 things. One, Homer and Shakespeare were right. And 2, the perspectives that I'll give to you and go through here are from 3 different hats that I wear. One is as a policy practitioner. I've had the great honor to serve my country and serve my state under 4 presidents and 3 governors. That's the state of Virginia. And I run healthcare agencies, aging agencies, and disability agencies. I have the great honor right now of serving as the president of the American Association of Kidney Patients. And as I'll show you on the slide, its roots are here in New York. It's the oldest and largest with over 125 or 130,000 members right now. And this third hat I guess I wear is just as important. I'm a patient. So I've managed kidney disease for 37 years. And I am 21 years out on a kidney transplant and lived for 2.5 years on dialysis. And just out of curiosity, has anybody in this room ever sat down with a doctor and had a doctor tell you that you have a limited number of years to live? Welcome to the club. And the reason why I put that out to you is because it's very important to focus on, because if it's not you, it'll probably be a loved one at some point. But let me roll through here and give you a couple of different perspectives, especially when it comes to implementing policy. And I know a lot of people talk about that. I've actually done it, and what it takes to actually make something happen and to drive change and to make services available for individuals. Go right ahead. History matters. So for context, in the first half of the 20th century, kidney disease was a death sentence. And I think probably from history we understand that. And in the 1960s, late 1950s and the 60s, you had the advent of dialysis care. A lot of tough decisions were made about that. A very historic institution is represented here today. That's the Rogerson Institute, which has a tremendous amount of longitudinal data and experience helping the least among us, people that suffer from kidney disease. And what happened was dialysis began saving lives. Patients talked to one another. And you had different systems in the United States that began to more programmatically provide it. Some specialty hospitals and the U.S. Veterans Administration. Next slide, please. This is me at UNOS headquarters in Richmond, Virginia. And this is what the dialysis machine looked like, the big washing machine in the 1950s. And I go down there frequently. I serve on the board. And it's a good thing to keep that in mind. The machine that I lived on, which much smaller, and I could take it with me wherever I went. Next slide, please. This is the cover of Life magazine in 1962, and just to bring into scope for you the stark reality of this actually happened in many folks' lifetimes or in the lifetimes of parents. Next slide. And in that magazine in 1962 was this photo and this article, and it's called They Decide Who Lives and Who Dies. And it was the panels that actually decided who got dialysis treatment. Now for context, and this is important, I was born in 1964. My parents remembered this article, so when I got diagnosed, their frame of reference was, what is his future? And it had tremendous impact on our household. I was 16 and kind of, going for broke and lucky. I didn't really focus on it until it started to interrupt the things that I wanted to do in life, and became a barrier to aspiration. Next slide. So I mentioned that AAKP, the organization I'm the president of, has proud roots here in New York. It was 6 patients in Queens County Hospital who were receiving life-saving treatment on dialysis who thought, we're the lucky ones. How do you expand this out? How do you save more lives? And so those 6 patients working with their doctors got organized, did letters around the country, that type of thing, and they brought legislation forward in Washington, D.C., and one of those patients was actually dialyzed on the House Ways and Means Committee floor in front of the United States Congress. Try to get that machine in there today. Good luck. But that law actually was passed in 1972 and signed by Richard Nixon in 1973. It's called the End-Stage Renal Disease Act, and that's what provides dialysis treatment in the United States. That act alone is estimated to have saved 1 million lives since 1973. Next slide. So this is where we stand right now in terms of the world and the United States with kidney disease. 500 million people have kidney disease, 2.6 million are on dialysis, and in the United States alone, 40 million suffer from it. You have 700,000 who need dialysis or a kidney transplant to live, 120,000 new patients go on there, and you can see the numbers. The one I'd have you really focus on is the mortality rate, 50% at 3 years, 60% plus at 5 years. And most disturbingly, I think, is increasingly at a younger age. So when we start to get into some of these issues about palliative care, I know we're focused on those who are aging, but I think you also have to focus on some of the other populations, because increasingly at the younger age among African Americans and Hispanics, there's a higher occurrence that's being detected. Next slide. So what is the cost of this? In the United States, it's $98 billion. And of that $98 billion, about $33 billion is for those who are on dialysis, and the rest are for those who suffer from chronic kidney disease. This is just a quick snapshot. Next slide. But the true costs, and one of the things that inspires folks like me and our organization to get involved, is the cost that sometimes is not calculated and that you can't see, and very much the root of our discussion here. It's the cost to patients. You can take a look at all these things, but really you're talking about human life interrupted and aspirations thwarted, and many times that's complicated even more by the difficulties of treatment. People don't advocate enough for home-based treatment, for transplantation, so really your life is tethered to a dialysis machine. Next slide, please. So what do we do as an organization? We educate, we protect the right of patients and their doctors to have confidential conversations and not let other folks intervene in those conversations. We organize patients, and we advocate. And what we advocate for really in the truest essence is this, that treatments align with human aspiration and that people are not limited. Next slide. And so when you're in an advocacy organization and when you're working in public policy, I think we all understand this, but principles shape the norms and they shape policy. And so what are some of the principles that we operate on as an organization that represents essentially the care of 40 million Americans? Number one, living longer is not a bad thing. That's a good thing. Number two, policies must avoid the exacerbation of stigma, bias, and unacceptability toward the aged, disabled, and the sick, and prevent the erosion of the culture of empathy for others. Palliative care gives comfort to the suffering, but it's not a means to accelerating natural death. And in a truly civil and free society, religious and cultural beliefs and institutions are positive influences, not hindrances or roadblocks. And I think this is very important to keep in mind as we talk about a framework and a system for care, because government alone cannot do that, but nonprofit and religious institutions play a very fundamental role and a very important role. And the final point I'd say is, again, government alone is not the solution. Next slide. So here's where we are. We have a set of principles, you have advocates, and I think one of the most interesting things that's happened in the 12 years is the evolution of technology in terms of advocacy and how, at least in the United States and in other countries, the person that has the simple cell phone has disproportionate influence on impacting policy. I work in politics, but you can see the evolution of technology. If you come down here to the last bubble, it's really the effectiveness of social media in driving policy and policymakers to make clear statements about what patients want and what patients deserve. Next slide. And on the right-hand side, you have a graphic. On the left-hand side, this is a great story. This is just 4 or 5 weeks ago. This is about 75 kidney patients who in 1962 probably wouldn't be here, but here they are on the steps of the U.S. Capitol, dozens of meetings, requests for additional funding for NIH, which we were able to secure. But basically, it's the celebration of life and the celebration of effectiveness as advocates. Next slide. So when you're trying to impact policy and we have these discussions, at least in the United States, and we talk about policy ecosystems and what do you have to influence, oftentimes people want to run down to the United States Congress and that's where it stops, or they would blame the president for not doing something. But I think it's particularly important to understand that at least in the United States, and I would argue in many other countries, these are the types of groups that are actually in the ecosystem that you must influence simultaneously. And with the power of patients and advocates, it's easier to do. I always put as a joke, patients at the bottom of this diagram, but really they should be the centermost. But it's the patients that actually can drive decisions within the ecosystem. Next slide. And so what is all this effort for? At least in our world and in this disease group, essentially this is what we're trying to affect. A system of care that's built on an inherent human desire to live, to aspire and to prevail. And that for kidney disease, the disease itself, to create a system that's patient-centered, defined by early detection, early intervention, and the availability of additional means to treat people. And for our country, in the U.S., it's the fundamental rejection of a status quo that has essentially existed since the late 1960s, which is dialysis care in a center, not based in a home, not intervened with early, with the exception, I would say very strongly, of nonprofit dialysis providers, which do a very good job of holistic care, including palliative care. And this is a tagline that I often end with different audiences, but why should a nation of innovators, which the U.S. is usually a description ascribed to us, why should we settle for the status quo? And our job as advocates is to shake it up. Next slide. So after all this activity, the principles that we operate on, what's happening? What you're seeing more and more here, and I think this is also true in different countries around the world, you had traditional roles that patients and advocacy organizations would play. People would come to them, they'd do patient surveys, they'd put them in a registry, they'd ask them to review different things and serve on panels. But what you're seeing now is a completely different dynamic. Patient groups are much more sophisticated. They're pushing for real-world evidence to be included in clinical trials, patient preference information, and there's a true transformation on it. And what you're seeing now is government also coming to patient advocacy groups and asking questions like, is our language appropriate? And that's why I was making the jokes about Shakespeare and Homer, because I have to tell you, the non-starter in domestic policy in the United States is run out with a banner that says, let's all get organized for end-of-life care, and you get folks like me, we're going to work day and night against you. But the fact is that there's actually common ground, and I'll get to that in a second. Next slide. So in policy, these are the great things we've been able to achieve in a very limited amount of time. HIV to HIV organ transplantation. That didn't exist 10 or 15 years ago, but patient advocates drove it. And a salute to the HIV and AIDS community because they really defined, I think for this country, one of the best examples of how to get engaged, study the issue, and take action. They've been an inspiration to so many of us. You're also seeing transplantation policies change so that older people can get organs from older donors. But I think the most important things that are going on now are the inclusions of patients in driving policy at the federal level. These are just a few examples here. Probably the most exciting was announced just several weeks ago by HHS, and that's Kidney X, essentially an innovation program where you have private sector and federal dollars commingling to jumpstart change in dialysis and in kidney care in the U.S. and to create more promise. You also have the advent of artificial implantable organs coming, driven by both scientists and patient advocates to, again, shake up the dynamic. Next slide. So in this context, what are some of the barriers to palliative care? And I'll put these out as somebody who has worked in political coalitions for a very long time across the aisle, not all partisan. And I don't think some of these issues are partisan, actually. I think they are what I call the cause larger than yourself, noble things. But I do think that these are barriers and that we have to keep them in mind. Fear and suspicion, especially among different patient organizations. And I would say in the United States that in the African American community, the Tuskegee example from mid-century is something to keep in mind, because many of the patient advocates I work with, they remember that. And they educate folks on it. And there's a lot of mistrust that can be triggered if you don't know what you're doing and you don't know what you're communicating. I also think we saw some language here earlier about the definitions of what it is and what it is not. I think that has to be very clear, because what a regulator might hear for palliative care or a payer might hear might be completely different than what a patient or a patient's family expect. You also have cultural disconnects, technological disparities, but you also have concerns that changing the norms on certain things and how you define care might actually negatively impact insurance coverage or medical coverage. People will be seen differently, or outcomes will be seen differently. And the last point that I'll raise here, since we are at the United Nations, is I think we have to be very careful that in the hands of government, definitions of what care is and who defines the quality of care and quality of life can often be used for ill-suited purposes, with negative intentions and negative outcomes for patients. And I'll put that out there because I think it's one of those things that when we're talking about changing norms, you have to go back to what are the principles that underlie norms and policy. And you have to make it absolutely clear that you're not trying to encourage the end of life sooner than you would expect or a patient would want. Next slide. Some personal observations. I've had a lot of conversations over the years with a lot of really outstanding professionals, and it's one of the reasons I'm here. I always bug my doctors by saying I'm here for a lot of reasons, but especially my nurses. They cut to the chase and they keep you alive. But I would say that in this debate that we have, and when we try to extend policy and create policy, there are some folks who are so sterile in their approach that you think, boy, what a blessing, because I don't think in their life they've ever been impacted by a doctor sitting down across the table and saying, you've got a limited number of years, or maybe they haven't progressed to the point in their families where they're actually taking care of somebody. But they're very sterile and disconnected. I think other folks just can't figure out how a tremendous amount of pain and stress in terms of your health actually gives you strength. And I'm not trying to be like Goethe or somebody else here and put this out. But oftentimes a patient will go through things that your imagination, it won't reach that point. And your understanding won't reach that point. And the reason why is because they're fighting to see their grandkid graduate, they want to finish college, they want to own a home, they want to feel like they started a career and that they left something for their kids. It's a very, very powerful force. I think probably the greatest power of that is we do the largest patient conference every year in kidney disease. And to hear the stories of people and see them come in, literally focus on the shade of death because they're trying to make it to the granddaughter's graduation, it's an inspiration and it's a source of inner strength. Next slide, please. So I think this has been touched on, and I'll make this the final point. These are a series of questions that when you're working in coalitions, you have to ask about who you associate with in order to achieve policy. So whereas one day I may argue with you or oppose you in a coalition and try to stop your legislation, these are questions that when you sort out who's working alongside you can oftentimes prevent a lot of misunderstandings. And I think that's very important, especially in this debate, because there are some folks that articulate a different view. I would call it a starker view, and that's the utility of a life, the cost of a life, and the cost of care without thinking of who the individual is. Last slide. This is what I call a performance metric. These are 4 individuals, 3 of my friends and I, at the White House under President Obama at an organ summit. So this is 4 folks with 12 kidneys among them. We're all transplant patients, celebrating what a great event it was that we could actually impact policy under a Democrat president and work very diligently to make certain that those same achievements weren't lost under a next administration. And that's what we do. But I wanted to lay these things out here for you because I think sometimes the patient perspective is not fully represented, and I'm glad to have had the chance to do that. Thank you.
Our next speaker is Ms. Tanya Manning. She is the Chief Actuary at the United Nations Joint Staff Pension Fund. She is also a lecturer for Columbia University's Master's Program in Actuarial Science. And prior to joining the United Nations, she worked as a policy actuary at the U.S. Department of Treasury. Ms. Manning, thank you.
All right. Can you hear me? Yes. Okay. Well, thank you so much. It is quite a pleasure to be here. Just for clarification, I am the consulting actuary for the United Nations Pension Fund, so I work in that capacity, not a direct employee of. But it is, I can assure you, first of all, that I am not going to repeat any of the slides from my co-presenters because I am not actually focused on palliative care, but I am focused on something that I feel is quite related, which is the income that is available to individuals and the longer term in their longer lives and in their retirement, as we often say. As a pension actuary, I focus on numbers, so I have more charts and graphs than most of the co-presenters, but don't be intimidated. You're not required to do any calculations during my presentation. So it's a little late in the day for that nonetheless. So what I am going to talk about is the perspective that we take as pension actuaries and also in a policy perspective. Is first of all, as a pension actuary, I focus on pension schemes or pension plans, as they are called, and focus on the longevity of individuals that the longevity of individuals that impacts the cost of these pension plans. So as pension actuaries, we're very much on the financial side, typically when we're advising on these plans and how much they're going to cost, either the nation that sponsors them, the company that sponsors them, or the organization, as is the case with the United Nations. And, but also, as a pension actuary, I've become to quite appreciate the importance of having lifetime income throughout your life, or what we're starting to refer to as enough income to have a dignified retirement. And as such, I do spend a lot of my time focused on what we call lifetime income and chair a task force through the American Academy of Actuaries that focuses on that topic and making sure that we have policies that encourage opportunities as such. In fact, my co-chair for that task force is met on the Hill in Washington, D.C. to talk to staffers about possible policy changes to encourage that. So to understand why these policy changes might be needed, I'll go ahead and proceed into my presentation. So next slide, please. So again, I will be focusing on the income side of the equation, which is very important when you get into your longer years and you have resources that perhaps aren't provided through any type of health care through your government or your private insurance. And when you think about retirement in the United States, which is not different than other countries, there are 3 sources of income. There would be the social insurance, which is referred to as Social Security in the United States. Social insurance is typically a federal program that serves as a safety net of income. The second, which is my focus, is defined benefit plans. These are often referred to simply as pension plans, and they are offered by employers or organizations to provide an annuity or a stream of lifetime payments to the individual throughout their retirement years. The third is simply savings, which to me is just savings, but it can be applied for retirement, it could be applied for buying a new car, it could be applied for lots of things, but savings is also another option, and those can be provided as well. Next slide, please. So this slide I'll spend more time on than others, based on what I think would be of interest to this group. And this is a graph that I created to make a point, and I apologize, it's quite simple, but it has a really important point. And this is looking at, if you, is a graph where it is showing the increase in the growth, the U.S. is but one example of the global trend towards savings plans as longevity simultaneously increases. So what it's trying to do is something similar to what Dr. Morrison was talking about, is showing that if you look at the red line, you can see that there has been an increase in the longevity for individuals, which means that they are having longer lifespans versus their work spans, so longer periods of time where they need income, where they're not working to earn that income. But the green bar is showing the decline of defined benefit or pension coverage. And the reason this is important is that the defined benefit plans are unique and different than the savings plans, or as we call them in the U.S., the 401k plans, because they are providing a guaranteed level of income to the individual. So as the need for these types of sources of income have increased, the opportunities for this income has declined. And we'll talk about why these Social Security or insurance programs are typically not sufficient. But again, focusing on this slide, the reasons this is important is if you are moving a society, as we are in the United States, from a source of income that is guaranteed for life to a pot of money or a savings account that they have to manage on their own, it creates a lot of problems and concerns for the society. First of all, the individual is going to be at a disadvantage in their ability to invest their money, and this is both due to financial literacy, but also their access to funds that have efficient fees associated with them. So if you are a very large fund like the United Nations Pension Fund, you are able to go and find these efficient investment options and negotiate and do quite well. If you're an individual with a very small amount of money, you're going to spend a lot trying to get those options to save, and it's going to be quite difficult. The other issue with this is the end-of-life inability to manage your money. If you are very much dependent on the amount of money that you saved, perhaps you can figure out how to do your budget and manage this, but once you get to the longer portion of your life, and when your cognitive skills decline, you're not able to manage your income as well as you could. And if you don't have that guaranteed check coming in from an annuity, from a defined benefit plan or social insurance, hopefully both, then you're not going to be able to do that. And not even included in this is we are seeing that seniors are becoming prey for those who have these savings accounts and people coming and trying to take advantage of them because of their inability to understand how to manage their finances. And finally, and the most important from a pension actuary, you can go to the prior slide. I'm going to skip a lot of these slides. I'm going to talk about the prior slide, if you could. Or not, okay. But the biggest thing that actuaries think about is when you put someone in a social insurance or a pension fund, you're pooling the risk for that individual. And as Dr. Morrison pointed out, and he almost became an actuary in his presentation, was that if you have a life expectancy of a certain number of years, that does not mean that you can plan your savings for your life expectancy, let's say, is age 80. Because when you look at the life expectancy, half of you are going to die before that, and half of you are going to live longer than that. And the problem is that you have to what we say self-insure, which means you have to save enough money to last for as long as you could live, not as long as you actually do live. So it creates a very inefficient system. So the fact that I'm looking at the current slide that we have is that the savings do not always become lifetime income. Again, when you have this savings approach, you end up having different issues where folks do not end up saving or preserving their income, and you can see that this is actually an issue not just with the U.S. but in other countries. Let's move to the next slide, please. So is social insurance enough? What I found in my research is that there's a tremendous amount of global variability in the income that you receive from these government programs, and it is often seen as a safety net, so it will be able to have someone meet their bare minimums. But as they get older and they have more needs for income, these are not going to be sufficient in many cases to achieve what we call that dignified retirement or an adequate level of income. And you can look at this more closely later if you have access to the slides, but let's move on. That are being provided. And that's exactly what's happening in the U.S. And one of the reasons they're increasing in cost is the extended lifetime. So as the expected future mortality, which is the way we think of it, means that people are living longer, then these plans are costing more, so they are being converted to savings plans, or they are simply being cut back. Next slide. And so mortality is a key driver, so the longer the life, the more these plans cost. This is an amplified version. It's not quite as dramatic if you look at different ages, but it gives you a sense of just how much this can increase the cost of these pension benefits. And it has a lot of references to mortality tables that I don't have time to further explain. Next slide, please. And this gives you a sense. There was a recent update to the assumptions that actuaries use in determining the liabilities that plan sponsors have for offering these benefits to their employees. And you can see the estimated increase just in this recent 10-year update increased the liability from 2.3 million trillion to almost 2.34 million, so quite a bit of an increase. And the prior slide saw that this trend has been continuing and continuing. Next slide. So what is more troubling, what is in addition troubling to the decline in the defined benefit plans is that even the plans that continue to exist, they were created to provide this pension or annuity income, but plan sponsors are reacting to this mortality risk and increase in longevity by providing what we call lump sum payments, which means they go to the participants in the plan and they provide them a one-time settlement or cash out for the value of the future promised checks. So they get one big check at one time, which converts them into all the problems I discussed in having the savings plan approach. And there are other options that are being explored and used by plan sponsors, but in the U.S., the decline in the defined benefit plans continues, and in addition, the defined benefit plans that exist continue to push the participants toward the savings plan approach. Next slide. So just to give you a very quick and brief look at the United Nations Joint Staff Pension Fund, which some of you may be interested in. This fund is a very large pension fund. It is a defined benefit plan for the employees of participating organizations. And the majority of the benefits are provided through an annuity, which means lifetime income, checks payable for life. There is an option to get a percentage of your benefit as a lump sum payment, but you can receive all of your benefit in the form of an annuity. And due to the long history of the plan and the size of the plan, they can customize the mortality for this plan and do a better job of estimating the longevity. But even with that, the experience is no different than the U.S., where we are seeing an increase in the longevity of the participants and therefore the cost to the plan. Next slide. And this just gives you a graph. I guess I took out some of the graphs. It was not as many graphs as I thought, but this is just showing you the recent update that we did last year to the mortality assumptions, and these lines just show the probability of death at the different ages that are illustrated, with the black line showing the prior and the red showing the future. And you can look at this and see how this varies for the males on the top chart and females on the bottom chart, and at the different ages. Next slide. And this gives you a little brief shot at the life expectancy. And what's important here, actuaries, we don't like to talk about life expectancy because we feel that's a very flawed way of thinking about how much income you need, because as I mentioned, your life expectancy is just what you might live, but you very well could live longer, and that's what you actually have to plan for. But in this slide, we're showing that there is an increase in the number of years of expected lifespan. So that makes you understand that there's an increase in the number of years that this pension fund is going to have to pay checks to the individuals who participate in that. And that was what's important to the fund for the reasons illustrated on the next slide, please. Well, actually, go to the next slide. This is my last slide. You'll be very happy, Anna, to hear. Yes. Perhaps you will too. I hope not. But so this is the really the thrust of what is going on, and this is illustrative of what's a challenge for the United Nations Pension Fund, but for every pension fund and also social insurance program in the U.S. and globally, is that at the top you see that you have the original expected lifespan from hiring age to death, if we think about it that way, because it's from hire to death is typically when your benefit is funded. You can see that in the green bar when you have the amount of that lifespan where you are contributing, and the red is where you're receiving benefits. If you expand that lifespan, as you see on the bottom illustration, the period of time that you're contributing or saving, or the employer or nation is putting aside money for your retirement benefit, is becoming smaller, or maybe the same size, but proportionally smaller than the amount of time that you have to receive the benefits. So while you only saw a few years change in the life expectancy in that latest update, this is a continuing trend, and it's troublesome because now we have to compress a lot of savings and cost into the accumulation or contribution phase versus the number of years of receiving benefits. This is going to break some of these schemes or pension plans that you see throughout the globe, and it is a true problem. But it's not only the plans, but it's also the individual savings, because you think about how long someone can actually earn money and save money for their retirement. It can only be extended so long, but as we have different ways to extend people's lifespans, they need money for many more years. So the ratios are kind of off, and it's a continued problem. The policies that we are looking at from the American Academy of Actuaries, we do not advocate for policies, we inform policymakers. And one of the things we want them to be very much aware of is what they're creating when they move from these pension schemes into these savings accounts approaches. Because for all the reasons I mentioned earlier, and for this change in the ratio of the accumulation versus the decumulation, which is a real world only in the actuarial scheme of things, is becoming very skewed and creating quite a problem. So that is my presentation for today. Thank you so much for listening.
Thank you so much. I'd like to, for panel feedback, before opening the floor to your questions and comments, give the mic to Dr. Bruce Gelb, who is the president of the Global Bioethics Initiative. He's also a transplant surgeon at NYU's Langoon Medical Center. Dr. Gelb.
Thank you very much. And, are we on yet? Thank you very much. And I would first off like to thank the panel for coming today, for our discussants, and the expertise on the panel today is truly thoughtful. On behalf of Global Bioethics Initiative, I would also like to thank the Permanent Mission of Romania to the United Nations for co-hosting today's event, and to the Permanent Mission of Croatia and Ambassador Drobnjak for addressing us with opening remarks during this session. It's clear that there is a need for thoughtful strategies and for policy development for the world's aging population will continue to become increasingly important over the next several decades. We obviously have many challenges to face. We jokingly say that 40 is the new 30 and 50 is the new 40. And unfortunately, 70 is not the new 60, it's 70. And if you paid attention to Dr. Morrison's talk, 40 used to be today's 80, so we're in some impressive times over the last century. We've made some substantial changes and strides to improving health and activity as we age, though there are disparities that remain through regions of the world, as has been discussed today. We've witnessed in the last century the shift from the ability to age to what we're now addressing, which is the right to age healthy and with dignity. The system of palliative care and hospice has been developed predominantly in the wealthier nations of the world, and it has been identified as critical to the entire world and the world's population. The World Health Organization first addressed this in 2014. There's much room for further development, and much of the world's population does not have access to these services. Of course, everything comes at a cost. There's a financial impact for caring for an aging population. Comparative increases in the resources have become more necessary, and there's more room to absorb these financial burdens in higher socioeconomic countries, but the impacts are felt by countries worldwide, regardless of wealth. Caregiver support is obviously an issue, particularly when the rate of increase in the percentage of older citizens exceeds the rate of the population growth of the younger generation. As we face these novel challenges, the impacts of aging and increased longevity will result in increasing cooperative advancements in health, prosperity, sharing, and collaboration. This is how we got to having the problems of having a healthy and aging society at this point. And I think today's panelists have highlighted some key issues that need to be addressed going forward. If I had to sum up today in one sentence, we've done an incredible amount in solving life's problems, and in the same process, we have created life's problems. So I will turn over comments in just a moment to Dr. Oreskovich, but to start off with the first question for our panel, we'll do it. I'd like to do it speed dating style because we're short on time. So if each of you think about the answer to your question while Dr. Oreskovich is giving his comments, but from each of your perspectives, what's the one thing that you feel is critical in developing sound policies to improve end-of-life care worldwide? Thank you.
Well, I think, Dr. Gelb, you said that our panelists can have time to think about your answer. So, Dr. Orosovich, I'd like to introduce him, Stephen Orosovich. He's Vice President of the Global Bioethics Initiatives. He's also from the University of Zagreb School of Medicine, Andrea Stamper School of Public Health. Your comments.
So, it's a pleasure to be here in UN, and my mother, she is 95, and she has plans for the next 10 years. Her name is Anna, so I don't think if we can use this as a predictive methodology, but I think there is a very simple answer to the question for the longevity, and it's actually if we are oriented towards the future or towards the past. And I think there is a kind of genetic program which creates us, older we become, more oriented towards the past. So the key question, I think, for the panel and for the discussion we are having here is how we understand the trends of the time we live in of today, and what would be the future looking like in 10 or 15 years. Because what will happen in 10 to 15 years is probably already decided today. So another institution I'm associated with is just organizing a conference, three days conference on the definition of brain death. It's a Harvard Medical School, and it's because there is now 60 years of definition of brain death. And when you listen all these discussions, you can recognize that in 60 years, a lot of changes happened and a lot of technological progress also. But our ability to answer to the moral questions was not following the technological and economic development. So the question, the key question still remains, what is the right thing to do? Because we have heard today many comments about trends and disparities, and we have a huge technological disruption. The big 5 technological companies, Microsoft, Amazon, Google, Facebook, and Apple, are probably at the moment influencing the healthcare and the future of the healthcare more than United Nations, national governments, WHO, and many others together. And we are completely living in the parallel and disconnected worlds, being even not informed about what's going on. And these 2% of the well-off that are spending 40% of resources dedicated to the healthcare in the United States are probably those which are finding way to the new technologies, to 5 times heart transplantations to reach 104 years and so on and so forth. So I think that because we are at the UN, we should understand that there is a need to change the format of discussion. We need to have everyone around the table, because if the public institutions and democracy will travel on one rails and capital concentration and technology development on the other, we will find out in very few years that we are maybe in one of the worlds, we are not deciding where we want to allocate ourselves. And just to illustrate for the end how culture and values are influencing where we are going, so what is the right thing to do? That's the key ethical question. Influence of definition of brain death And political and cultural attitudes towards the dead are so influential that country from where I am coming, Croatia, has at the moment the highest donors rate in the world, 40 per million. And Japan, which is much richer and much more developed country, has only 2.5%. And it's not because of technology, it's not because of science, it's not understanding medicine, it's because of culture and values in the world we are living in. So we need to, I think the first question is how we can bring at the table everyone who is making decisions, and then how we can answer the right questions. And that would be the question if we can continue ignoring that our time has expired.
Thank you so much, Dr. Urasovic. I wanted permission, Dr. Lida, do you think that we can have one or two questions from the audience before we wrap up, or do you think everyone is looking forward to the cocktail reception venue at the Beekman Tower where you can biddle? What is your preference? Closing statements from the audience. Please introduce yourself if you have any questions, limited to 1 minute if you have any comments, and the floor is yours, whoever would like to ask questions. Yes, sir, please.
Yes, thank you. My name is Cornel from HEALS, Healthy Life Extension Society. I will continue in the same direction as you were saying, the last speaker. We live longer than ever in the history of the world, and palliative care is in most cases, or almost all cases, only necessary during the last years of life. And you know that there are people and organizations dreaming or thinking that we can someday defeat senescence. But like you said, the people who dream about that, they are not in the United Nations, they are not a lot in the public organizations, they are the GAFAM and also in China. So I think this is one of the big mistakes of public institutions at the moment. It's not thinking about that, and maybe I would like to know what the members of the panel here think about what we could do to promote scientific research, medical research for a life with a very limited senescence, where palliative care for, concerning aging is less and less, would be less and less necessary.
Would our panelists, thank you for the question.
you.
I think would our panelists, would you like to talk about that? I think that he's talking about care outside of societies that are fortunate enough, for example, to have representation at the United Nations, and what you think we should, how we should proceed for those societies.
Well, I think we are facing multiple challenges for which we are definitely not equipped in many ways. To start with, I think we really have to seriously invest in generating adequate evidence. We do not have proper data, we do not have properly disaggregated data to do analysis and to tailor our actions to where the needs are. So I think we are having massive gap here, and I hope that within the whole 2030 agenda, where the big data issues are so high on the agenda, this will help. So once we know better what the scale of problem is and we have good projections, I believe that we are facing a problem that we are constantly breaking many problems into silo issues, and we are trying to advocate, be it for palliative care, with all respect, or tuberculosis care or other care, and not just in health, but in many other ways. The challenge is that there is nobody in any country or in the world, like United Nations or any other institutions, that are able to one by one answer all those things and ensure that there are financial resources available for everybody, so we can talk as much as we want, but in reality this will not happen. So what we believe is that we have to be looking at integrated solutions. We have to combine the problems, and we have to look at the system transformation that we need to do to accommodate interests, not just people with a kidney failure or the cancer or whatever, but also people who want to give birth to their children and not die, like we have so many millions of women dying today from very simple issues. So I think that's going to have a global integrated discussion around the same table, not just healthcare people, but many other sectors as well. And we have to look at evidence that we have and prioritize things collectively instead of going to say, let's have advocacy for this or advocacy for that. Advocacy is also unfair on those who are not able to advocate for themselves, especially people in palliative care or aging societies, etc. So somebody else has to do that, and that is responsibility, first of all, of the government, but government cannot resolve this alone. It has to be resolved together with private sector, civil society, communities, and healthier dialogue between all the partners.
Okay, one more question, a Q&A format, please. You, sir, you raise your hand. Yes.
Stefan, can you hear me?
Yes.
Stefan Benedict, coincidentally from Romania, but I'm here for 42 years. On my private case, I just retired. I'm almost 70, and I'm depending on federal government for social security and city government for my pension. So altogether, if I would be to live another 25 years, I could, the government, either city or the federal, could save from me, if I die tomorrow, $2.5 million. So this becomes a bioethical question in my mind. I would like one of the specialists to address this.
One of our specialists in less than a minute. Can you please explain this?
I'll take a shot at it.
Okay.
I think basically what you're saying is that if you were to expire tomorrow, which none of us would wish, and congratulations on being 70, and congratulations on having two sources of income, including a pension, there would be a realized savings. So one of the roles that I used to have, and I was talking about this earlier, I had served as the Chief of Staff of the Department of Labor. And I think, going to Dr. Gelb's point here, I think some of the things that I think are positive for folks that are at your age are efforts that are being done to better align the talent and knowledge of folks who are older in society with the problems that exist, and being able to do it in a way where you can actually make money if you wanted additional income. So whether that's online business, that type of stuff, I think there's a move toward redefining what work is and a move towards redefining what retirement is. And I think that's critically important because the artifice of retirement at age 65 or 67, I think no longer matches intellectual pursuits and people's capabilities. So I would hope that technology keeps advancing, that we keep redefining what work is, and that all along the aging continuum, we value people's insights and equip them with the tools to make it a commodity and to monetize it. That would be my hope.
Thank you so much, Mr. Conway, and I think that that was an answer to Dr. Gelb's question as well. The good thing is the conference is ongoing for another day or two, Dr. Annalita,
I
thank you.
asked the conference management we can stay 3 to 4 minutes. The more we stay, the more we pay. But I think we should not stay longer, much longer. Anyone else having an interesting question, an intriguing? Yes.
Palliative care is still a relatively new field, as has been pointed out, and we need a whole lot more healthcare practitioners going into the field, doctors, nurses, social workers, etc. We have some wonderful palliative care programs. Dr. Morrison is at Sinai, a leader there, and there they have probably the best palliative care program in the world. But we still need to establish many, many more in other hospitals and nursing homes, etc. I want to just point out that there is a bold law that was passed in New York, which may not, and other states in this country and countries may not be ready for a law like this, but I want to mention it because it's a law that's called the Palliative Care Access Act, passed in 2011, which requires in New York State that all hospitals and nursing homes who have patients with advanced life-limiting illnesses who do not have to be terminally ill must be provided with information and counseling on their palliative care options, including pain management, and must be provided with access to palliative care. And those hospitals and nursing homes have to have devised policies and procedures to ensure that that happens. So I think it's something to consider if we want to push the envelope a little bit and try to ensure that more places have palliative care programs and services sooner than later. It's something to consider.
Thank you. Thank you, David. The lady, 1 minute. We still have 1 minute. So I promise we will organize a conference with this topic and everybody.
I'm assuming that this is on. My question is I would just stand. In terms of paying for the caregivers who provide the palliative care, what about a movement towards paying the family members who provide the palliative care in terms of tax breaks and making that not a state-by-state option, but a national and international movement? So I'd like to hear your thoughts on that.
Okay, Dr. Morrison is going to answer.
Yeah, the question was how do we pay for the caregiver workforce, and how should families be reimbursed for the care that they provided, because in many respects they take time off from their work. The answer, my perspective is yes. That is under the Medicaid program in New York State, for example. There are provisions to do that. Other countries, Canada, for example, has legislation in place so that family caregivers can be compensated for the care they're providing. It is certainly something that I would see should be spread much further than those two countries, but it still does not solve our problem of the fact we will not have enough caregivers in the current situation, and we need to focus on that.
A big round of applause, please, to our applause to all of you. Thank you so much. If you would like to send your questions to us, you are welcome. And you just have all the particulars, so www.globalbioethics.org, and you send your question at aelita@globalbioethics.org. Thank you so much. We'll be in touch. Thank you.